Welcome back, everyone. It's great to have you here again virtually. And it's my honor and pleasure to present you with Dr. Jim Whitfill of Honor Health in the Phoenix area. Dr. Whitfill, thank you so much for joining us today. We appreciate it tremendously.
Absolutely, Mark. It's really great to be here virtually, and hopefully soon we can all begin to safely start to be together physically when it's convenient.
Yes, absolutely. So Dr. Whitfill, why don't you, before we plunge into the substance of our discussion on leveraging data analytics for population health, tell us just a little bit about yourself, personally, professionally, and about Honor Health.
Absolutely, Mark. So Honor Health is a not-for-profit community health system located in Phoenix, in the Phoenix area, Maricopa County. We are a 6-hospital system, a little over 12,000 employees. An integrated health system with an extensive outpatient presence, including affiliations with an area FQHC, food bank, and 6 different hospitals. So we see the entire spectrum. We also have a clinically integrated network called Innovation Care Partners, where I used to be the chief medical officer. In ICP, as we call it, we have a number of well over 150,000 patients in risk contracts. Those include MSSP, Track 2, and which has downside risk, Medicaid, Medicare Advantage, commercial. So we've had a lot of experience with managing what people would call either value-based care or population health in that space. So like a lot of systems, we are trying to navigate the transition from fee-for-service to fee-for-value and have feet in both of the proverbial canoes.
Yeah, absolutely. And you yourself are a primary care physician by background, and you practiced for many years.
In fact, one of the things that I love about my position is I still get to practice. So I'm, as you mentioned, Mark, I'm internal medicine trained doctor for adults, for those in the know. And I am able to see patients a couple of afternoons a month, and I teach in our internal medicine residency program. So not only do I get to be with our patients, but I get to be with our young physicians as they are learning how to become full practicing physicians.
That's wonderful. I appreciate it. And I think I'm certain that that also adds to the great credibility you already had with your colleagues in your space.
It's powerful.
Yeah, good, good. Well, tell me a little bit. First of all, let's go back to the risk-based contracts you have. If you can just kind of summarize the different, you're in at least one ACO, I know, and you're in some other programs as well. Briefly take us through those, and then we'll talk about the leveraging of data to support those.
Absolutely. And Mark, you and I have had some conversations in the past about this, and I think that one of the things that was a big eye-opener for me was learning in the value-based care world how you manage populations in different products is actually fairly different. So just because you've had experience in being successful, say, in the Medicare Shared Savings Program, that does not automatically translate 100% to others. So if we start off to your question, we think about MSSP as sort of a classic Medicare Shared Savings Program. It's been around now for several years, based out of CMS, and is oftentimes the first place that organizations begin to kind of cut their teeth in terms of managing risk, either upside and downside. For Honor Health, what we've done is, because Honor Health was formed as a merger back in 2014 between 2 health systems, Scottsdale Healthcare and John C. Lincoln, each of them had their own population health entities. Yeah. So we've had 2 ACOs in the past. We've merged them together, which itself is a whole task. But today we have well over 50,000 covered lives in our MSSP program. And so far, we've been able to save money every single year since our inception back in 2014, and something we're proud of, something that's not easy to do. The work that you do, though, in the MSSP program is different from even Medicare Advantage. And so a number of folks are partners. Either they might have their own Medicare Advantage plan. We don't have our own Medicare Advantage plan at Honor Health. We partner with a number of area payers, Medicare Advantage brings its own different set of challenges. So certainly cost management and clinical management is important, but you start getting very focused in things like the STARS program, which is a quality program, which really drives financial outcomes, as well as managing the correct amount of risk through what are called HCC codes. I might pivot, and then in Arizona, our Medicaid program is called Access. It's still a demonstration program, but it's a managed Medicaid program. But I think anywhere in the United States, when you deal with the Medicaid population, all of a sudden you have a whole nother series of skills and capabilities that you need to have when you're in the population health space. A lot of behavioral health becomes very, very important. You need to be able to work with oftentimes very disadvantaged folks with a number of socioeconomic challenges. And so being able to meet people where they're at, while that's true for all of those populations, really becomes important in that space. And then finally, in the commercial space, it's yet another. So now you're dealing with generally people that have their healthcare through an employer. So these are working adults. Now yet another area where what you're doing around value-based care and population health requires yet a separate set of skills. So we can go into any of those, Mark, if you'd like to, but I think it's important for our audience to understand just because you have success in one of those areas, it doesn't automatically translate to the next area.
Well, without getting too much into the weeds, because I know we could talk about that for a great length of time, at an incredibly superficial level, Doctor, what do you think is fundamentally different between Medicare Advantage and MSSP? Is there something really different between the two?
Yeah, there are a couple of things. So the first part would be the MSSP program is uniform across the United States, right? So you're dealing directly with CMS. There are national rules, and there's a complete transparency of data, which is actually pretty powerful in terms of what you need to do to manage that population. The other piece on the MSSP side is you're really 99% of the time, your main lever of influence is managing cost, and then quality is important because you have to report quality scores. But your quality scores determine, for example, what proportion of savings you're able to keep. So the higher if you have savings, then your quality score in the MSSP space just determines how much of that savings you're able to keep. So that's in the MSSP space, really it's really important to figure out how are you going to manage the total cost of care for those patients, and make sure that the quality measures that you're going to report on are high. Those are true in Medicare Advantage, but there's another piece, the STARS metrics and the risk metrics around HCC scores also determine the amount of premium attached to those patients. And for our viewers, let's use the following example. Imagine, let's use Mark and I as the examples. Mark is very healthy, has no other medical illnesses. We can estimate that his costs in a year are going to be lower than, let's say, if I have heart failure and I have diabetes. So if I have diagnosis codes attached to me to say I have diabetes and I have heart failure, we know that the premium cost will be higher because we expect that the actual cost of care will be higher. So when you're managing a Medicare Advantage contract, documenting accurately and correctly and fairly the conditions that a patient has are just as important as managing the quality scores. So that documentation becomes much more important than, for example, in a MSSP program. Interesting.
Does it make it harder for clinicians to be in multiple programs? I mean, I'll just stop there and ask that. Yeah, it does. Okay.
And I think that for clinicians, and this is why I enjoy practicing, we don't, despite what people think, I don't walk into the room and say, what kind of insurance does this patient have? I'm going to treat them differently, right? I try to have a clinical model the same for everyone. And one of the things that we've taken the approach at Innovation Care Partners is we just try to say, we're going to have one model of care across all of our patients, taking into consideration sort of the average or the bulk of these value-based care programs. because really as clinicians, it's very hard for us to shift our thinking, from room to room to room.
Yeah, exactly.
What we do want to think about is maybe making sure we've got different types of resources that we can draw upon. So again, if I'm seeing a Medicaid patient, I want to make sure that I have access to better behavioral health, for example. Whereas for a patient who's over the age of 65, which I'm getting closer to, so I appreciate, we want to make sure that we have care coordinators who can deal with multiple chronic illnesses at the same time and help navigate across those.
Interesting. I appreciate that. So let's talk about data.
Yeah, love data.
Yeah, good. Data loves you. What? Let's start at 45,000 feet, shall we? And then kind of drill down in quantities of 5 or 10,000. At that high level, I consider you and your colleagues to be in an advanced organization. Many patient care organizations are just really beginning down that journey that you're already fully involved in. What have the biggest lessons learned been so far in terms of what one learns as one begins to mature in the use of data analytics for all of these advanced the alternative payment models?
I think there's probably at least two. I mean, we could talk, this is another topic where we could probably fill the entire time diving into, but when I think about it, there are at least two overarching things that I think are important to learn. The first is getting experience with claims-based data that tells you the total cost of care is probably a multi-year journey for most folks. And oftentimes as clinicians, we have experience with clinical data, so EHR and being able to kind of pull things out. But the reality is, on the claims-based side, it's a very the pictures are murkier. It's more like an impressionistic painting rather than a crisp photorealistic painting if you're an art lover. And you need to develop the capabilities to understand where you can trust the data down at a detail level versus when do you have to make broad inferences. And in general, what we found is with claims-based analytics, which is critical to be able to manage total cost of care in a population, it often might take you 3 to 5 years, which is a long time to develop that acumen. And so that's why I encourage people who are on this journey to try to get that part started as soon as possible, because you're going to probably skin your knees on a lot of cases, managing that data. So start early. The second piece, Mark, that I think has been really important is how do you merge clinical data with financial data? And when I talk about financial data, I'm talking about that claims-based data. And it's not a one-to-one. People sort of think of there's going to be this magic black box that brings it all together, and you have this, again, sort of perfect photorealistic picture. But there are trends that you can link between the two of those. And again, learning how to aggregate that clinical data can become really important. I'll end this part by saying that one of the other challenges is there are a few organizations out there, let's choose Kaiser Permanente, for example, where they have really a closed kind of population. The EMR really has almost all of the clinical data that population is encountering. But the reality is in the United States, about 80% of people get their care in community systems or in environments where they're getting care across multiple different systems. And in that environment, you have to think about the clinical picture has to be more than just the EHR of one system. And how do you build that larger clinical picture?
Absolutely. Does health information exchange help?
It does. I mean, it's certainly, one of the things that we invested in early on at Innovation Care Partners was putting in a private health information exchange. When we look across our clinically integrated network, there are 60 different EHRs, one of which is the Honor Health's Epic. Then there are 59 others for all of the specialty and primary care physicians that are out in that space. So we're not going to get everybody onto one EHR. So we've used a private health information exchange in order to aggregate that data. And at the same time, in Arizona, our statewide health information exchange called Health Current, although I think they've recently adopted a new name, has really begun to mature. So health information exchanges, I think, are a really critical part of doing just what you talked about.
And by the way, Doctor, I just have to pause at 59 EHRs plus the system EHR. It's like, wow, WOWWW.
Well, that's what a lot of people usually say when we share that fact. The liberating, I'm a person that likes to find the lemonade in the lemons. The liberating thing about that fact is it pretty much takes off the table any attempt to get everybody onto the same EHR. So once you say that's not our strategy moving forward, it lets you look at other approaches to create sort of a virtual umbrella across your organization. And that's something we've been able to be pretty successful at.
Very important. Tell me a little bit about, this is a discussion that has been floating around for years, data people. There's this classic question, do you hire internally from healthcare and teach people about data science? And analytics? Do you hire from outside healthcare and then teach them about healthcare? I hear every kind of answer in the world and combinations. There are organizations that are doing both. Talk to us a little bit about that, because one of the things that I respect so much is to be successful in all of these programs, you and your colleagues and everyone who's involved in all these programs, you really have to be good with the data. You can't just be sloppy and, horseshoes and hand grenades about it, right? You actually have to know, you have to understand your populations, you have to be able to provide dashboards to the clinicians, you have to be able to look at panels, all patients, all those things. So how do you get enough of the right people who can really crunch the numbers for you?
Wow, Mark, you always ask the hard questions. We can talk about
politics. I'm a journalist, hey.
Yeah, let's talk about politics and religion next too.
Yeah.
No, it's actually a great question. It's one we debate internally a lot. And so what I'm going to hedge is if you can have even a medium-sized team of 5 or 8 people sort of working with your data, and certainly larger, in the end, I think having a mix is great. I do think that there is a value of having people that have a deep understanding. Let's talk about some of the specific skills in data. There's entry-level pieces in terms of understanding, how do I query a database? How do I begin to put information together? How do I even understand the information in that database? And one of the things that we find that's certainly useful about people with a clinical background is if you are just beginning to look at, kind of pulling data out of a really large database, you oftentimes need to have some sense of what's normal or what's realistic or what's plausible when you begin to join different things together. So for example, I'll just be silly here. If I told you that I just ran a query against my database and 98% of people, in Phoenix had brain tumors, you would say that, now I'm being very ridiculous, but you'd say that doesn't make a lot of sense. I know that there are brain tumors out there, but it shouldn't be up at that level. But if you get into specific things, having that knowledge of a little bit of clinical knowledge can help you. Sometimes if you're not doing your queries correctly or you're trying to match up data sets. But what we have found is that probably the hottest topic that everybody's dealing with is there's just an acute shortage of anyone to work in the data sciences area.
People.
So yeah, exactly. So what we're doing is we will take clinical folks who are interested in data and we will train them up. We are increasingly, though, hiring on people that have experience on the data side and teaching them on the clinical piece. I will tell you, I think that takes longer to teach the healthcare part of things to people that know data. Just because it's healthcare is just it's a complex space.
You have given me the answer that I've asked like 100 people and you're the first person who has actually pinpointed that. That's what's been in the back of my mind, doctor. Like, is it harder to teach healthcare or harder to teach data, working with data and analytics? And you're saying it's harder to teach healthcare, which is interesting to me because I am one of those people who likes to balance out. We always hear healthcare is unique, and it is unique, but also in some ways there are analogies with other industries. However, I would tend to agree with you, and you're the one who knows because you're living this. But my observation is that healthcare is so different from other industries that it is hard to, I've interviewed people who were data leaders in, say, the retail world, retail sales world. Wow, when they get into healthcare, they're like, whoa, this is different from, how you determine if you're doing well on selling sweaters, right? Like, it's just much more complex. So maybe just elaborate a tiny bit more even on that.
So I think Mark, I think it's spot on. So two things that I think about when you bring up that topic. The first is, I think one of the things that throws people off when they come in from outside of healthcare is we have the illusion of standardized data, i.e. we have databases that have fields within them. But what a lot of people don't realize is some of those fields are probably very reliable, like the patient's age. That's, I'm sure you can find some problems, but patient age is probably a very reliable field. Yeah. But ICD-10 code or ICD-9 code or CPT codes, there's a lot of noise in those, right? Because those are things that you might think are pointing to the clinical condition of a patient. But in fact, oftentimes clinicians are just trying to choose the code that works for that sort of scenario. Yeah. So understanding that certain elements of your data are very reliable, others are sort of directional at best, I think that really trips up folks that are coming in from the outside. The flip side would be, when we talk about training clinical folks in data, I can teach people how to do queries, and I can teach them about navigating different sort of database environments, largely because there's a lot of tools now that make it easier. But if we get into really advanced topics like regression or statistical analysis of significance or artificial intelligence, convolutional neural networks, or k-means clustering, or all of these really advanced pieces, that starts to get pretty challenging. And that's where I might say, hey, if I can have somebody on my team that, even though they don't understand the healthcare as much, they really understand different types of predictive tools, that can be a great mix to have in your team.
Yeah. And that's what I'm hearing, basically, is that leaders like yourself and others in other organizations are bringing together that combination. They're bringing together, like hyper great data people, twinning them or pairing them with, in many cases, a lot of these people are coming from nursing, who are coming out of healthcare, but they understand. And as you said, when they start looking at those specific types of data, they immediately understand that there's something wonky, then we need to go in and look. They know what to look for. So it's like, I don't know, I often use, maybe because I'm multilingual, but I use linguistics examples, and like, you need interpreters, right? So the interpreter here is the combination of two types of people, right? So it's the clinician who has been trained to work with data, and the data person who's learning more and more about healthcare. And that's how you figure out what's going on, right? So give me just a couple of examples of where you and your team have really made some nice strides, and you boast a little bit.
Oh, absolutely. So I think one of the things that's been really, two areas that we've spent a lot of time learning, just even kind of across the organizations, is, let's first talk about claims analytics. As I mentioned, very difficult to do. But now that we've spent 6 or 7 years ingesting claims-based analytics across all of those different types of the spectrum that I mentioned earlier, the different products, we've become much better at being able to not only look across the entire population, but explain to our clinical colleagues what we're looking at. Because the first thing we have to do is set the stage that we're not looking at like EHR related data. This is not clinical data. So we have to coach them again on what's going to be very reliable, what's going to be directional. But being able to look across, so for example, let's use me. So if I want to say, Dr. Whitfield, do you tend to manage your outpatient patients with asthma well? Like, are you able to keep them from having to go to the emergency room, which is nobody wants to do, particularly in a time of COVID? You could start with, well, Dr. Whitfield, with your insurance carrier A patients, we see that you're an outlier and maybe you need, I don't know, extra training. Well, the first thing I'm going to say is I'm not sure I trust that data, right? Because that's what physicians do. But one of the things that we've been able to do is aggregate across now 5 or 6 different products and sort of say either, and this is actually more often than not, yes, you're an outlier with product A, but it turns out you're actually managing those patients really well across all the other areas. So there's probably just a statistical anomaly. That builds huge amounts of credibility with the clinicians. Yeah. So that's been really important. The flip side, though, is one of the things that we've been really successful in is we will bring, I'll take an example, back pain. So we'll bring our clinical experts together and say, we think back pain is a challenge in our value-based space because of how much we spend. And we'll have orthopedics surgeons, neurosurgeons, physical therapists, anesthesiologists who deal with pain, emergency medicine physicians, and we'll show them the data. We won't even guide them. We'll just say, this is what we're seeing. What do you all think we should do? And we found that to be a really powerful effort rather than forcing an opinion upon the clinicians, letting them just have access to this higher level view. And they oftentimes come to really insightful ideas how we can manage that population better.
And I think that also speaks to the fact that I know that you're a very modest person, but you have great credibility as a physician leader and you remain partly in the trenches. And I think that helps a lot, honestly.
I think one of the things that we've seen is that putting physicians, first in terms of making these decisions rather than trying to impose decisions upon them, it makes all the difference in the world. And you can get to the same place that you need to go, but allow physicians to see what, and come to their own conclusions. It's not unlike when I teach my medical students, I find that if I use a discovery method and I let them come to a conclusion, they remember the material a lot better than if I just lecture to them.
Yeah, absolutely. So, no, very, very true. So let me ask you a question with 2 parts. What does the next few years look like for you and your colleagues at Honor Health in this area? And what does it look like to you, kind of scanning the industry?
Well, let's start with the latter. I always start these kind of conversations with, if I was really good at predicting the future, I would probably be like Warren Buffett. And I can tell you my portfolio does not, I invest in index. I invest in index funds because I don't know what's going to happen. But I will tell you, I am very concerned about the state of healthcare in the United States. I personally don't see how we can continue on the current trends that we have and be sustainable. And why do I say that? If you look at the macro level, the percentage of our GDP that we pay for healthcare continues to rise. That makes it very difficult for our national industries to compete in a global arena. At the same time, we know that there's a huge imbalance in terms of government plans tend not to be able to even cover the cost of care. And so oftentimes that additional cost is being supported by commercial plans. And I think we're reaching the end of how that works. So we know that this sort of house of cards of how we finance healthcare in the United States is just getting more and more unstable. And I wonder about, we certainly continue to try to tweak little parts to it, but I am concerned that another major shock to the system like COVID has provided is going to force us to really look at that fundamental funding mechanism. I'm not advocating, some people would say, well, then you need to have single payer. Others would advocate for a completely concierge approach and cash out of pocket. I'm not going to take a position between those two, but I think it's hard to look at the entire system and say it can continue at the current rate. And while I'm a huge believer in value-based care, I love, to be honest, as a physician, I like how the incentives in value-based care reward me for keeping my patients healthier. I don't know that we've seen the bang for our buck that we need to completely fix the whole system. So value-based care is part of the solution, but I'm not sure it's going to be the only solution.
Yeah, I think absolutely, doctor. I mean, there's this very broad debate happening right now, and I don't want to fall too far into that, but I'll just reference it. Dr. Don Berwick and Dr. Rick Gilfillan wrote rather a searing blog in Health Affairs, basically attacking Medicare Advantage. And I interviewed for our Southern California event, virtual event. I interviewed Don Crane, who's the president and CEO of APG, American Physician Groups, and he basically takes an opposite viewpoint. The only reason I reference this is all of these debates are circling around a core fact that you mentioned, that the system is becoming unsustainably expensive. The Medicare actuaries said 2 years ago that we are going to go over 6 trillion from the current 3.6-ish trillion, over 6 trillion in the next 5 or 6 years, which is astonishing, right? I mean, and I sometimes wonder whether, I mean, physicians, nurses, all clinicians, you're like the smartest people on earth. Seriously, I admire you so much. But I think maybe sometimes it is too much for clinicians to consider the bigger picture, right? Like you just have to focus your energies on your patients, which I totally get that, right? Like if you were thinking about the overall healthcare system 24/7, you'd go insane and jump off the top of a building. But I do wonder whether clinicians realize that the level of expense that's coming now because of the aging of the population, mm-hmm. and because of the absolute explosion in chronic disease, whether some clinicians fully grasp the dimensions of this, right? Does that make sense?
It makes total sense. And the model I use to try to explain that, Mark, is that because I find the exact same thing. I look at it at a macro level in the United States. How much are we spend of our GDP are we spending? It's on an unsustainably large amount. But if you look at the micro level, if you look at the operating margins of most health systems, it's on the lines. It's like a grocery store. It's incredibly small. Resources are incredibly tight. So it's hard to mentally reconcile how can resources be so tight at the local level, and yet at the macro level, we're spending so much. And that is what leads us to this. You actually have to realize those two things are happening simultaneously.
Yeah. And I will say one other super big picture comment, all healthcare systems in the world are dealing with this now. So for example, in Japan, they have the fastest aging population in the world. They literally cannot sustain their healthcare system because their population is aging so fast. There aren't enough young people supporting the healthcare system, supporting health insurance in Japan. And so in 10 years, they're going to get to the point where it will be just crushingly expensive for them. There's no easy answer. We have to take care of people. We have to be a caring society. But as we age, I'm at the young end of the baby boomers. And as the baby boomers get older and older and older and older, I feel it every day, that is affecting our ability to support the system. And as you know, because you're caring for people, this explosion in chronic disease is very, very scary in this country. So I agree with you completely. What I will say to bring it back to this discussion is, you and your colleagues at Honor Health and those who are doing similar things in other organizations are really doing God's work here, as they say, right? Because you're the people who are figuring out how to break it down, right? And so why are we spending X amount on Mrs. Smith versus X amount on Mr. Jones when they appear to have virtually the same clinical profile, right? Let's say they both have diabetes and CHF, and they're the same age, and they've had basically the same medical history. But we're spending X amount on Mrs. Smith every year, and we're spending X plus 30% on Mr. Jones. And when you are able to find out why, you're able to fix a piece of this whole thing. So that's why this is so incredibly important.
Absolutely. I think you mentioned Don Berwick earlier. And so, we know that there are huge amounts of waste and inefficiency in the system. Some have said up to 30% of our spending. The challenge is, how do you reliably find that 30% so that you can remove it from an inefficiency perspective, but not jeopardize the care of a patient? Because we certainly don't want to deny care to someone where it would be appropriate.
And I do think that you all, I would say we, but I'm not doing anything. I'm just reporting on it. But you all are making real progress in that area. And that's very exciting. So just leave us with one piece of advice of any type related to this subject.
Well, I think that there's the old saying that a journey of 1,000 miles starts with a single step. You mentioned how one can look at the challenge of how do we fix healthcare, not just in the United States. This is true across the globe, right? This is a global phenomenon. How do we manage with an aging population, doing more with less, and also managing people who have multiple chronic illnesses? Yeah. These are expensive and labor-intensive challenges, and so you might look at that whole thing and say, it's just impossible. I'm going to throw my hands up and just focus on what's around me. And yet this is a challenge that I think we all have to face. So let's take that first step in that journey. Let's begin to learn, how do we take on these challenges really in our own communities, in our own neighborhoods, with our own patients? How do we learn to manage in these new spaces? And how do we make new innovations so that we can care for more people in a way that makes our physicians and advanced practice providers actually happier, makes our patients happier, where we spend less and higher quality, that quadruple aim. It's one of the hardest problems that we face. And yet, if we engage, I fully believe in the magic of innovation in the human spirit to find a way out of this challenge.
Yeah, well, that's a very hope-inducing final comment. We really appreciate it. Thank you so much, Dr. Whitfield, for your time and your energy and your wisdom, because we need about 100,000 more of you out there in the healthcare system.
You are too kind, Mark. It's always a pleasure to talk with you and your audience. I love the work that you all are doing in terms of spreading education. So thank you. It's an honor to be here.
Wonderful. Thank you so much. Well, this concludes this session. Thank you to all of you in our audience who have participated, and have a great day.